Thank you everyone for joining today. As people join the meeting, I just want to let everyone know that today's webinar is being recorded and it will be sent out via email to everyone who registered. Today's webinar, The Lead and Copper Rule, Opportunities for Nursing Action, is hosted by the Alliance of Nurses for Healthy Environments Policy and Advocacy Forum. The Policy and Advocacy Forum co-chairs are Atinas Mina and Kathy Curtis, and they will be on today's call. 1 hour of nursing continuing education credit is available. Participants must complete the evaluation and post-test for credit, and we will share the evaluation and continuing education link near the end of the presentation in the chat. And it will also be sent out with any resources shared by presenters to those who registered. Please do put your questions in the chat while our speakers are speaking. If there is time at the end, we will have a question and answer, time permitting. And as we get started, if you could take a moment to introduce yourself, what type of nursing you practice, and where you are zooming in from. And if you are not one of the speakers, please do make sure you mute yourself so that we can hear everybody who is speaking. Our first speaker today, we are joined by LaTricea Adams. LaTricea is the founder, CEO, and president of Young, Gifted, and Green, formerly Black Millennials for Flint, a national environmental justice and civil rights organization with the purpose of bringing like-minded organizations together to collectively take action and advocate. If you could please mute yourself if you're not a speaker, thank you. What I was saying, sorry. LaTricea is formerly of Black Millennials for Flint, which is a national environmental justice and civil rights organization with the purpose of bringing like-minded organizations together to collectively take action and advocate against the crisis of lead exposure, specifically in African American and Latinx communities throughout the nation. LaTricea is a proud HBCU graduate. She is the youngest African-American woman appointed to the White House Environmental Justice Advisory Council, and she is a former member of the American Bar Association's Environmental Justice Task Force and was a recent honoree of the Environment, Energy, and Resources section's Dedication to Diversity and Justice. LaTricea is a proud native of Memphis, Tennessee, and we're so excited she is joining us today for this webinar. LaTricea, I'm turning it over to you.
Thank you so much, Sarah, for that introduction. And my apologies in advance. My voice is a little scratchy, so I won't be able to use my regular teacher voice, but hopefully you all will be able to hear me clearly. Happy to speak on this topic this afternoon. So the three talking points that I want to ground us in: one, I want to uplift the principles of environmental justice, which will ground us in the foundation of our conversation today. So first, talking about why are we talking about lead today, and then honing on a bit deeper into lead poisoning and color, specifically the impact of lead poisoning and lead exposure on Black and Brown communities. And then I'll round out with the importance of frequent blood lead level screening, which I know should resonate with this audience today of wonderful nurses. So first, why are we talking about lead? So when we look at this map here, this map is a little bit dated. So it's dates back to 2016. We have a huge crisis around lead poisoning and lead exposure. It's a public health crisis. And so we see in this map here where the most severe would be Burgundy, and then it goes down to about 1. So this is based on pretty not that great data. So there's some places specifically when we think about the Southeast that's not even accounted for. I know some of my colleagues on the panel this afternoon will speak in greater depth to that. But we see specifically in the Midwest concentrated risk of exposure of lead, whether that be from lead service lines, whether that be from lead paint. Lead is historically and currently a pervasive issue that disproportionately impacts community of color. Excuse me. So one key thing that I want to ground us in as well is that there is absolutely no safe level of lead for anyone, regardless of age, race, gender, socioeconomic status. I know very often we hear about the implications of lead exposure and the impact that it has on children, but there's no safe level of lead for any person, regardless of age. Also, just really quickly want to uplift, and I know today's focus is on the lead and copper rule and implications as it relates to lead service lines, but there's a myriad of ways in which you can be exposed to lead. Oftentimes from a residential perspective, often we think about exposure through lead paint, also through lead service lines, but I also want to uplift exposure through plumbing as well, whether that be in fixtures inside of the home, also other plumbing inside of the home as well, particularly if you're in a home that is dated, that has not been modernized. Additionally, you can be exposed to lead with consumer products. So for example, cheap toys, sometimes toys that you get from like a dollar store, oftentimes they're imported, they're plastic, can also have traces of lead as well. Painted ceramics and even beauty products have been a cause of lead exposure as well. And then also I want to uplift soil. Soil also can be a contributor to lead exposure as well. So moving into a key component around who's being impacted the most as it relates to lead exposure. So particularly Black and Brown communities, more specifically Black communities, Latinx communities, Indigenous communities are the most at risk for exposure. However, African American or Black communities are the most at risk. Particularly Black children are more likely to have higher blood levels than white children. And some of those attributes include poverty. So Black children are more likely to live in economically distressed communities or low-income communities. Also, the legacy of racial segregation, where the housing stock, whether that be in homes, single-family homes, multi-units, are oftentimes Black families are in substandard housing that has significant exposure to lead, again, whether that be in lead service lines, whether that be inside of the home with plumbing or lead paint and the like. Also, Black children are more than likely to live in houses built before 1978 that contain lead. If you look to my right here, we see a breakdown by race as it relates to blood lead levels. So while it's high across the board, we see a pattern where Black children in particular are the most disproportionately impacted by lead exposure. So I wanted to uplift some specific examples, again, highlighting that this is not only just a public health issue as it relates to lead exposure, it's an issue surrounding environmental racism as well. So as Sarah mentioned, I am a native of Memphis with Texas roots, but both maternally and my parents met in South Memphis. They're from the Riverside community. I uplifted this community as an example because in Memphis, being in the South Memphis was one of the few places where Black people could live. Jim Crow is heavily redlined as well, and it still has legacy pollution issues to this day. I use this particular street and the zip code because this is where my father grew up. If we look at this map, this is a lead service line inventory map that's pulled from Memphis Light, Gas, and Water's lead service line map. And the green dots indicate that there is no lead present. The gray dots indicate that there is lead present. And then yellow means that it's unknown, but you should err on the side of caution and go with there may be lead present. So we see that there's a significant amount of issues with lead service lines. And I also want to say that even with this map, it's only giving you information about what exists on the private side of the line, meaning that the line that connects to the main water main. However, it does not indicate if lead exists on the private side. So essentially, it could be possible that where you see these green dots, that there could exist lead on the private side, but this map is inadequate, which is another conversation which may come up with some of my colleagues that'll speak later in the panel. I also wanted to pair this with some other information around socioeconomics. So we see these series of gray dots, which indicates lead service lines. Let's take a little bit closer to talk about the people, the human beings that exist within this particular community. 75% of people who live in the Riverside community are low income. That means that only 25%, a quarter, don't live right with a low income. Almost the whole neighborhood is in economic distress. We also see that it is 98% people of color. I can speak to this because I'm familiar with and was born in this community. 98% of those people are African American or Latino. 18% in this particular community have less than a high school education. The average life expectancy is 68 years. I want to uplift my father, who is now an ancestor that lived and breathed and drank water in this community. He didn't even reach 68 years old. He died at 65. So just a true testament of how legacy pollution in communities of color are so pervasive as it relates to public health. I want to pair this with another example. So in East Memphis and Germantown, and this is in a different zip code, this particular community is among one of the wealthiest communities or zip codes in Memphis and one of the most affluent communities in the entire state of Tennessee. So for example, you see that the per capita income is over $100,000, right? We see the life expectancy of 81 years. So when we think about the implications of lead exposure, let's take a look at what this map shows. So we literally see no indication of lead service lines in comparison to the previous screen with this majority, right? 98% community of color, where we see a significant amount of lead service lines. So this definitely highlights the issue of this being very much so a racial crisis as it relates to lead exposure. I want to take it to the East Coast and give some additional examples in our nation's capital. So I paired two particular examples. So I use schools. I mentioned very briefly that I have a background in K through 12. I spent 16 years as a K through 12 educator. And so here we looked at MOK Elementary School, which is located what we call east of the river in Ward 8 in Washington, D.C. The majority of the Black people who still remain in the District of Columbia live east of the river in either Ward 7 or Ward 8. But in this particular instance, this is in Ward 8. Now, with this particular map is a bit more detailed. So it has a bit more of a breakdown around what the status is of lead service lines. So red is the key thing to look for, also with no information. So we see a significant amount of verified lead lines. We also see some suspected lines, lead service lines as well. Now, going to another example, another school, that's a public school, but it's a magnet school in one of the more affluent wards in Washington, D.C., which will be Ward 2. Now, it's a bit more spread out, but we don't see any indications of verified lead specifically in the radius of this particular school. When we compare this to what we see in Ward 8, where the children that attend this particular school and MLK are majority Black and Latino. Again, emphasizing that this is a racism crisis as it relates to lead exposure. Also looking at some other socioeconomic data as well. This is a comparison between Ward 8 and Ward 2. So there substantial differences. So we see a huge variance as it relates between low income, where it's 49% versus 21% in the more affluent community. Even looking at average life expectancy, there's a significant gap there as well. Also, something that is really key, that is an interesting point to explore, is that persons with disabilities is about 19% in Ward 8 in comparison to about 8% in Ward 2. So wanted to uplift that as well. While Black children are the most disproportionately impacted by lead exposure, again, no level of lead is safe for any human being. There are other significant groups that are at high risk of lead poison and lead exposure as well. So that will be young children, including children, unborn children or babies in the womb. Also immigrant and refugee children as well, birthing people or pregnant people, and also laborers. So those individuals that work in construction, those who work with housing, particularly those who work in lead abatement, folks that work with automobiles, whether it's small cars or trucks, those that work with batteries and also manufacturing are at very significant risk of lead poisoning and lead exposure. Excuse me. Also, something that I want to uplift to shift gears just a bit is the importance of frequent blood lead level screening. So, a key thing that remains an issue in the United States is the mere lack of testing. So, as of 2010, there were about 1.2 children that were reported as having lead, but that does not encompass or entail all of the children even being tested. Even with that 1.2 million, and this was quite some time ago, it's a lot more reported in 2024, only half of those children were even being tested. So a lot of the children are falling in between the gaps, are not getting the public health services that they need to ensure that they can live a better quality of life, even though they've been exposed to lead or been lead poisoned. In addition, testing for lead is not a federal requirement. So that means that the data that we have that even informs graphs such as this is really not sound because there's not enough children who are actually being tested. In addition to that, while again I mentioned that there's no safe level of lead for any human being regardless of age, we do know that childbirthing people are disproportionately at risk, and that is also not mandatory for testing of women and childbirthing people as well. And then another key thing that is near and dear to my heart is that it is not a requirement at the federal level at this point for testing for lead in school drinking water. While we do know that a lot of our schools, especially in communities of color, are old, have very dilapidated infrastructure, and in many instances are leaching lead. Also, filtering is also not a mandate or a requirement either. Now, there are 5 states that actually have mandatory requirements for blood lead testing as it relates to pregnant persons. Those 5 states are California, Illinois, New Jersey, New York, and Rhode Island. That is pretty dire in comparison, where it's only a small percent in comparison to the other states out of 50, where there's only currently 5 states that have that as a mandate, despite there being recommendations from reputable sources such as the CDC and American College of Obstetricians and Gynecologists that definitely recommend that this should be a mandate as it relates to guidance on lead testing. So as I begin to wrap up here, because I want to be respectful of time of the other panelists that are here, is the emphasis on making sure that we understand that lead exposure happens multiple times. It's not just isolated. So for example, you could be exposed through water. You could be exposed through paint. There's a myriad of ways that you could be exposed, and it can happen multiple times. For example, if you're a child that lives in an older home, you could potentially be exposed at your home. You could potentially be exposed at school. You could potentially be exposed walking back and forth to school. So testing twice before 2, which is a common mantra or a current practice, is just simply not enough. Chronic lead exposure is real, and it also can exacerbate other existing health conditions along with creating health conditions or poor health conditions as well. And then also with frequent testing, it also allows for more accurate and timely intervention to mitigate more harm or less harm from occurring with individuals, whether they're children or adults. And then also it increases the wealth of data that you have access to improve monitoring and management of data, especially as it relates to health management with those individuals that have been exposed to lead. All right, so I'm going to end there. I went a little bit over my time, but thank you so much for being able to share this afternoon.
Thank you so much, LaTricea. So much good information. And I know some of you have asked, our presenters are willing to share their slides. I know LaTricea so we will be sending those out tomorrow with the resources. Our next speaker is Dr. Yanna Lambrinidou. Dr. Lambrinidou is an adjunct assistant professor in the Department of Science, Technology, and Society at Virginia Tech and co-founder of the Campaign for Lead-Free Water. Yanna is a resident of Washington, D.C., and she and her family lived through the district's historic lead and water crisis of 2001 to 2004. In 2014 to 2015, Yanna served on the EPA's National Drinking Water Advisory Council work group that was convened to issue recommendations for revisions to the federal lead and copper rule. Her research has been featured in The Guardian, and she was invited to serve as advisor to former Michigan Governor Rick Snyder's Flint Water Interagency Coordinating Committee, which produced the nation's most public health protective lead and copper rule to date. Yanna has also testified at the U.S. House Democratic Steering and Policy Committee hearing on the Flint water crisis, Lessons for Protecting America's Children. Dr. Lambrinidou, I am turning it over to you. We can't hear you, or I can't hear you.
Can you hear me?
Yes.
Oh, okay, great. Great, excellent. Thank you. Let me just screen share for a sec. I'm sorry, I'm trying to get the...
While Yanna is working on her slides, please do put your questions in the chat for our speakers. If there's time permitting, we will get to them, but they can also answer some of them in the chat possibly. So please do put questions for our speakers. We have amazing resources here today.
Can you see my slides?
Yes.
Okay, perfect. I'm so sorry about this glitch. Hi, hello, everybody. Thank you so much for the invitation to speak at this very important webinar. And thank you all for being here this afternoon. I'd like to start by commending the ANHE for its strong advocacy for a health-based federal lead and copper rule. Being on the front lines of both patient and community care, nurses can indeed play a catalytic role in helping to align lead in water policy and practice with the science of lead in water and with fundamental principles of equity and justice. In this context, I will share with you first some highlights from the history and science of lead in water. Second, some common misunderstandings that are undermining our ability to achieve maximal public health protection from routine and yet preventable exposures. And third, suggestions for additional nursing action that I believe can have significant public health protective impacts. So some background. Lead plumbing was condemned for the serious health harm it can cause over 2,000 years ago. Roman engineer Vitruvius made it explicit that water ought by no means to be conducted in lead pipes if we want to have it wholesome. And Greek physician Dioscorides wrote in no uncertain terms that lead makes the mind give way. In the US, lead in water was recognized as a serious risk to human health since the mid-1800s. In the late 19th and early 20th centuries in Massachusetts alone, and I quote, lead pipes increased infant mortality and stillbirth rates by between 8 and 25%. In fact, in several towns, one need have consumed only 10 to 20 ounces of tap water per day to have ingested the same amount of lead as was contained in the recommended daily dose of lead abortion pills. In newspapers, the women's sections featured stories about children being poisoned by lead in water, and by the 1920s, cities across America began to restrict the use of lead pipes. But the lead industry fought back, and by the 1930s, it had succeeded in getting lead service lines. These are the lines that connect water mains under the street to individual homes, to be legally required in 33 major cities and 2 states, Pennsylvania and Massachusetts. In Chicago, lead service lines were essentially forced on property owners all the way up to 1986. Now, it's important to know 3 things about lead-bearing plumbing. First, that it's ubiquitous. Lead service lines, which are estimated to be between 9 and 12 million nationwide, are made of 100% pure lead. Although they're typically the greatest source of lead in water contamination, they are not the only significant source. There is also leaded brass, which can be found in almost every building, as well as lead solder, which can be found in about 81 million homes. Additionally, most plumbing materials in our buildings, like faucets, valves, meters, and solder, contain lead, even when they're marked lead-free. The second thing that's important to know is that lead from plumbing appears in dissolved form, like sugar in hot tea, but also in the form of particles. Lead particles are small pieces of pure lead, leaded solder, brass, or rust that tend to fall into the water erratically. Lead particles can easily exceed the EPA's hazardous waste threshold for lead. The photo of the aerator screen on the bottom left of the slide is from the kitchen tap of a child in North Carolina who was lead poisoned from food that was cooked with contaminated water. Indeed, scientists have found that food containing lead particles can expose one to more lead than a lead paint chip approximately the size of a penny. And the third thing that's important to know is that exposure to these particles is like a game of Russian roulette. You can turn on a tap many times and draw lead-free water, and then suddenly you can happen to catch a particle and ingest astronomical levels of lead. Now, studies deriving strong, although non-linear associations between lead-contaminated water and blood lead in infants, children, and adults first surged in the 1960s. EPA drew on these studies to accomplish two things. First, defend its decision in the Lead and Copper Rule of 1991 to set the maximum contaminant level goal for lead in water to 0. And second, to challenge the still prevalent claim that drinking water comprises only a small portion of total lead intake. In the Lead and Copper Rule of 1991, EPA asserted that for some people, drinking water can be the primary source of exposure, especially if the water is corrosive. As such, the total drinking water contribution to overall lead levels may range from as little as 5% to more than 50% of children's total lead exposure. Infants dependent on reconstituted formula may receive more than 85% of their lead from drinking water. As exposures decline to sources of lead other than drinking water, such as gasoline and soldered food cans, drinking water will account for a larger proportion of total lead intake. That was in 1991. This assertion has been echoed by several recent peer-reviewed studies, as well as by papers about the large-scale health harm that followed the worst documented lead in water crisis in modern U.S. history, which took place in my hometown of Washington, D.C. in 2001 to 2004. DC's lead in water crisis alone is estimated to have caused over 800 and possibly up to 42,000 childhood lead poisonings. And it is also estimated to have resulted in a 37% spike in fetal deaths. Lead's association with miscarriage and fetal death, impairment of cognitive function, adverse impact on the neurological, hematological, cardiovascular, immunological, and endocrine systems have been well established. In children, health harm from lead can be irreversible, especially for low-income and non-white children. Lead in water has also been associated with delinquent behavior and violent offenses. At the population level, evidence suggests that lead exposure and violent crime tend to be separated by a 2-decade lag. This may shed light on at least one possible factor, that is, DC's historic lead in water crisis of 20 or so years ago, behind the district's recent outlier status in relation to homicides. Now, on common misunderstandings, unfortunately, our national discourse is marred by several persistent but gross misunderstandings about lead in water. Some of these misunderstandings, sadly, are perpetuated by federal, state, and local government agencies, as well as by members of the medical, public health, and environmental health communities. Most importantly, they are undermining our ability to address this contaminant effectively. I will highlight just 4. First, drinking water should be So the first misunderstanding is that drinking water should be considered a possible source of lead only when a water utility fails to meet federal lead and copper rule requirements. In reality, the LCR, the lead and copper rule, is not designed to eliminate lead from people's water. It is designed to monitor for and address lead and water contamination events that are severe, persistent, and citywide. When a water utility meets LCR requirements, lead in water levels at individual taps can be low on a chronic basis, as well as acute on a more erratic and unpredictable basis. So in DC, for example, our water utility meets lead and copper requirements with flying colors, and yet its own monitoring results systematically show that 70 to 80% of tested taps release some lead at the time of testing, and that some taps release over 100, 200, and even 300 parts per billion lead. Far lower levels than these have been linked to lead poisoning in formula-fed infants, which is obviously a concern. The second misunderstanding is that to assess one's risk of exposure to lead in water, all one needs to do is have their water tested. But the inherent variability of lead release from plumbing makes standard one-time testing of limited value, if not at times utterly meaningless and even dangerous, because the results can generate false assurances of safety. According to one study, in cases of extreme lead in water variability, assessing average lead from a single tap would require over 1,200 samples. The third misunderstanding is that the best way to tell if someone has been exposed to lead in water is with a blood test. Yet the half-life of lead in blood is estimated to be approximately 1 month. Unless the test occurs within a few days or weeks after exposure, blood lead elevations can be missed. This is especially concerning with regards to exposures to lead particles, since lead particles can contain exceedingly high concentrations of lead and can cause acute but short-lasting blood lead level spikes. And the fourth misunderstanding that I'll share with you today is that our national surveillance of lead in children's blood in children's homes confirms that water is only a minor source of exposure. Unfortunately, this surveillance is focused on lead paint and dust and is designed to miss water as a primary and even sole source of exposure. Specifically, the two populations most vulnerable to lead in water, that is developing fetuses and formula-fed infants, are systematically left unassessed for lead exposure. When blood lead testing is done, it tends to focus on children around 1 and 2 years of age due to concerns about hand-to-mouth activity in the possible presence of lead paint and dust. It also tends to focus on so-called high-risk neighborhoods and children, again on the basis of provider assessments about the possible presence of lead paint and dust. And it routinely consists of a single blood test, which is inadequate for capturing past blood lead level elevations and spikes from water. Finally, when a child is diagnosed with blood lead levels high enough to trigger environmental investigations at their home, we routinely fail to check the water. And we fail to do so even when the paint, dust, and soil sources we find are unlikely to be the culprits. In those rare cases, when we do check the water, we routinely do so using methods that are known to systematically miss worst-case lead in water levels, if not miss contamination problems altogether. These and other common misunderstandings are discussed in more detail in an essay I wrote called Top 10 Myths About Lead in Drinking Water, which is posted in Lead Action News and on the Campaign for Lead-Free Water website if you're interested. Our website also includes a section on the science of lead in water, which features numerous important papers delving into many of the issues I just talked about. And finally, suggestions for nursing action. Because all people of all ages must drink water and cook with water to survive, because lead-bearing plumbing is present in almost every building, because the release of lead from this plumbing cannot be stopped unless the plumbing is fully and properly replaced, and because water can be the primary and even sole source of lead exposure, what's necessary for health protection is a precautionary approach. Such an approach must aim at preventing exposures effectively and immediately, no matter what one's blood test shows, no matter what one's water test shows, no matter whether one has a lead service line, and no matter whether one's water utility meets lead and copper rule requirements. It is scientifically warranted to assume that every tap is at risk of dispensing lead, and therefore it is morally warranted to amplify CDC's recommendation to run cold tap water through dually lead certified point of use filters as a rule before drinking and cooking. This recommendation must be accompanied with filter distribution programs for low-income households. Proper filter use can immediately and effectively reduce lead in water levels to or very close to the health-based standard of 0 in homes, schools, daycares, businesses, and all other buildings and outdoor areas with taps. EPA has a helpful consumer tool for identifying such filters. A second important precautionary measure is the full replacement of all lead service lines at no direct or indirect cost to consumers. Research has shown that water utilities' routine practice of replacing only the portion of a lead service line they own can actually increase lead in water levels and place people at greater risk of exposure in the short and long term. Yet EPA continues to allow partial lead service line replacements. And if it fails to revise its proposed lead and copper rule improvements before it finalizes them, it is likely that the billions of federal dollars which have been poured into lead service line replacement might result in a nationwide wave of partial replacements, might expose people to more lead under the guise of permanent remediation, and might also charge people for the work involved. This scenario raises grave and urgent concerns with regard to public health, equity, and justice, since these lines were often imposed on communities without informed consent, and since even EPA admits that its own regulation has to a significant degree failed us. Specifically, in some cases, the lead and copper rule has resulted in, and I quote, significant lead exposures, due at least in part to its improper implementation by many water utilities and faulty oversight by many states as well as EPA itself. Sadly, the LCR normalizes routine lead in water exposures and by extension normalizes associated health harms. Basic principles of reparative justice dictate that we finally shift the burden of unjust harm from the victims to those who caused or were complicitous in the harm. Toward this goal, we must work on patient and community empowerment to demand remedial interventions that are effective, equitable, and just. Relatedly, we must work on better regulations. When it comes to indoor or premise plumbing, people who have the opportunity to replace it should know to buy materials certified under the NSF Q equal to or less than 1 standard. This is a new and the most stringent lead in plumbing manufacturing standard to date. Lastly, patients and communities who want to utilize blood and water testing for protection must be told the truth about the limitations of such testing. Certainly, a high blood lead level or a high water lead level are cause for concern, but a low or non-detect blood lead level or a low or non-detect water lead level are not necessarily cause for celebration. People are entitled to this information so that they're shielded from false assurances of safety and better equipped to make informed decisions about how to best protect themselves, their families, and communities from exposures. Nurses are in a very good position to relay this message and help us begin a paradigm shift wherein lead in water policy and practice finally align with lead in water science and embody principles of equity and justice. Thank you.
Thank you, Dr. Lambrinidou. Our next speaker will be Erik Olson. Erik is a Senior Strategic Director for Health at the nonprofit Natural Resources Defense Council. Erik has 40 years of experience working on drinking water and toxic chemicals, and he has litigated and led campaigns to strengthen key laws, including the Safe Drinking Water Act. Erik has served as General Counsel for the U.S. Senate Environment Committee and was an attorney at the EPA's Office of General Counsel. His JD is from the University of Virginia and his AB is from Columbia. Erik advocates for safe and affordable drinking water for all, including vulnerable communities such as Flint, Newark, and other cities. He has litigated and led campaigns to strengthen key environmental laws. Erik, the floor is yours.
Thank you so much. And thanks for inviting me. And I'm going to try to squeeze my presentation down a little bit because I know we're limited on time. So I won't talk a lot about this, but the science on lead has really developed, as you've heard, to show that the impacts of lead are no longer what we used to think, which was impacts on children's brain development. But as you look at this literature, there is more and more data showing a wide spectrum of adverse health effects. I'm not going to take the time to go into them. We've heard a little bit about them, but I'm going to talk more about it as we talk about the rules that EPA has proposed. So obviously, who's most at risk is children and fetuses, Black and other minority children. But we need to remember that adults are also at significant risk from lead. And I'll talk about that in a bit. But cardiovascular disease, there's a lot of data that's come out in the last decade linking low-level lead exposure to cardiovascular disease, which is becoming extremely important as we talk about lead in drinking water. Now, you're going to hear a lot about these lead service lines. They are the pipes that go from the water main out in the street to the household, to the home. And that basically is something that we have to keep in mind because many of these pipes are partially lead now, as Yanna was talking about, and partially not lead. And unfortunately, a lot of water utilities to this day are partially replacing lead pipes, and that is a significant public health risk. This is from a study that we did a few years ago, looking at where the lead pipes are concentrated. EPA since has done a more recent analysis that's largely consistent with this, with the exception of Florida, where for crazy reasons, EPA says Florida has a lot more lead pipes than we think they do. EPA's estimate is around 9 million lead pipes. We estimated between 9 and 12 million lead pipes when we did a 50-state survey. These lead pipes are everywhere, in large part because the lead industry ran a big campaign that went on for decades, touting how wonderful these lead pipes are for public health. They're supposedly were going to be one of the great public health breakthroughs, according to the lead industry. And now, of course, we know that that was all false. We did a study that looked at EPA's data and found that at least 30 million people, just in this one period of time, from 2015 to 2018, were served by systems that violated EPA's lead and copper rule, and 5.5 million people were served by systems that exceeded EPA's action level, which is by no means a protective public health level. What this tells you is that we have tens of millions of people who are at risk from lead in drinking water. I wanted to highlight a recent development, which is Harvard School of Public Health professors Ronnie Levin and Joel Schwartz. Ronnie recently won Time Magazine's 100 Most Influential Health Innovators, largely based on a study that she did on lead in drinking water that was published in 2023. Among other conclusions, this is really important to look at. This is just a table from their study. They found that the benefit to cost ratio of addressing lead in drinking water is between 35 times more benefits to 51 times more benefits than costs. In other words, for every dollar you spend to help fix lead in our drinking water, you get at least 35 times that benefit in public health benefits. We took those data in collaboration with Ronnie Levin at Harvard and did a study we called Getting the Lead Out that looked just at the lead pipe issue, not the broad whole set of issues for reducing lead exposure. And what we found is a huge percentage, a huge amount of benefits from removing lead from our drinking water and removing lead service lines. $785 billion in health benefits, 14 to 17 times the cost. The vast majority of those benefits were from cardiovascular disease, but there are a lot of other benefits, as you can see here. The other thing that's important is this has very broad public support. This is from a poll that independent pollsters conducted that found that Democrats, independents, Republicans, non-conservative, independents, et cetera. There's the strong majority of the US population, about 8 to 9 out of 10 voters support a requirement to pull out all lead pipes within 10 years. So let's talk a little bit about EPA's proposal. The agency proposed this rule in December of 2023. And the good things about it are that most systems would have to replace their lead pipes in 10 years. It reduced the action level, which still is not protective, from 15 down to 10. We think it should have gone down at least to 5 parts per billion. It improved monitoring somewhat. So that's a mistype, sorry, from first draw as well as fifth liter. So both the first water that comes out of the tap and then water that theoretically should be coming out of the lead service line has to be tested. It improved the inventory requirements so that we would find out where the lead pipes are, and would improve somewhat some of the small system flexibility. There are many problems with the proposal that we're working to try to get fixed. One of them is that there are all these extensions. You'll see this is a chart directly from an EPA document showing that, for example, Chicago would get 44 to 55 years to replace all their lead pipes. So it's not everybody that gets their pipes replaced in 10 years. Other cities, Chicago, Houston, Cleveland, New York City, would get a long time to replace their lead pipes. The other concern is a lot of smaller water systems would also get very lengthy extensions from well over 10 years, in some cases 20, even more than 30 years in some cases. So we need to fix those extensions. We also need to make sure that water utilities are going to pay for a full replacement of the lead pipes. One of the problems we saw, you heard about Washington, D.C., and we see this in other cities, is sometimes the water utility tells individual homeowners, you have to pay for some or all of the lead pipe replacement. New York City, for example, just proposed to require homeowners to pay 100% of the replacement cost for the lead pipes. Well, this means that lower income people and most landlords are not going to get their lead pipes replaced, just exacerbating the environmental injustices. The rule also really needs to make sure that all the lead pipes are replaced, whether or not the utility, some utilities say, oh, we don't control the lead pipe, even though often they require them. They're saying, oh, we don't control them, so we shouldn't have to replace them. We need to fix that. And we also need to improve the public education and notification issues, as Yanna was talking about, and the school and childcare provisions, which we don't have time to talk about, are extremely weak. So that remains a significant issue. So the real opportunities for nurses, I just wanted to highlight a few of them. So this rule is very important, and it's supposed to be finalized just before the election. I listed 4 things that we think are very can help on. One is to urge EPA and the White House to get this rule done as soon as possible, certainly by October of 2024, which is when the Trump rule, by the way, goes into effect unless they get this new rule out. The second thing is that EPA is going to draft this rule and deliver it to the White House, this Office of Management and Budget in the White House. And nurses can ask for meetings with the Office of Management and Budget and say, let's make sure this rule is strong and health protective. Those meetings would probably occur in August or September. They will announce them, and I'll get to Sarah information when those meetings can be scheduled. It's too early right now, but we could be sending letters now. Third item is lead in school drinking water is very weak, as I mentioned in the rule. We would like to move towards a filter first approach for schools, which is rather than wasting all sorts of money on testing the water in schools, because we know when testing is done, about 8 to 9 out of 10 schools have significant lead problems. Rather than wasting money on that, let's install, as Michigan and Washington, D.C. both have now required, that all schools have a filtration stations where kids can get filtered water that's safe, rather than paying a lot of money and a lot of delays to rip out all the lead plumbing and maybe even replace it with plumbing that still has lead in it. And lastly, it's important to ensure and advocate that there's equitable distribution of money for Black and Brown communities with the new bipartisan infrastructure law funding. I know we've got limited time, so I am going to cut back on the rest of my presentation here, other than to say that we need more drinking water infrastructure funding. And we also clearly understand that these public health problems are significant, that there's no safe level of lead, that lead poisoning creates big, lifetime problems, and we need additional funding. And again, for nurses, these 4 items: urging EPA and the White House to finalize the rule as soon as possible, getting a meeting with the Office of Management and Budget in the White House when the rule gets delivered to them, addressing the school lead problems, and then finally making sure that the funding is available for Black and Brown communities to address their lead issues. So thank you very much.
Thank you so much, Erik. Our last speaker is Milagros Elia. Milagros is an advanced practice registered nurse and an early stage researcher in the environmental impact of climate change on patient care. And Milagros is also the program manager of climate and clean energy at the Alliance of Nurses for Healthy Environments. She chairs the National American Nurses Association Innovation Advisory Committee on Planetary and Global Health. And she is also a fellow of the American Nurses Advocacy Institute, in which she is focused on building awareness and developing educational toolkits on the impacts of climate change on patient care and outcomes. Millie, I'm turning it over to you.
Thank you so much, Sarah. And thank you to our speakers. This was a really great webinar presentation by all speakers. And with the time that I have left, which is just under 10 minutes, I won't recap things like the specifics on guidelines. What I do want to capture and highlight is nursing's role in education and primary prevention, really promoting blood lead screening in practice. So nurses in primary care are obligated to not just test, but educate, monitor, and manage, as well as manage lead toxicity treatment and lead testing. We understand that assessment and prompt interventions can prevent harm, primarily in children, but as Erik just mentioned, we can also see these same harms in adults. So understanding that lead toxicity can cause lifetime issues with behavioral, cognitive, or motor problems, as well as cardiovascular, hematological, and renal issues. We know through our training that lead toxicity signs and symptoms include abdominal pain, constipation, decreased growth, cavities, hearing problems, you name it, the child can come in with it. And here's the catch, or no symptoms at all. So when we are looking at our patients, particularly in pediatric populations, we need to really bring to the table our holistic training as nurses. And we need to look at the patients through the eyes, considering how ubiquitous lead toxicity can be. We really need to use our assessment skills to consider elements beyond our guidelines. And really, this really calls for us to consider aspects of the patient's history, like where they live. And in that, what is their ethnicity? And this calls us, in short, as practitioners, to really think outside the box and to be aware of our own patient populations within the communities that we are serving. So it is not a cookie cutter treatment plan or care plan for every single population. Now, patients that do get tested and do have lead toxicity, it is our role really to discuss all treatment options with patients and their families. And this includes environmental and nutritional interventions, as well as chelation therapy. I have about 5 more minutes. So with that, I just want to very broadly talk about the state where I live, New York, and what those guidelines look like for us, it resonates with a lot of what we've already heard in terms of testing children under age 1, and then again within the first 2 years. At every well child visit, we want to assess and address. These results must be reported, point of care bloodlet testing results in my state, to the Department of Health in accordance with this guidance. We need to give the parents and guardians of the children the results, but we also need to provide them with resources. So I'm going to make sure to drop into the chat box some of the resources that I've collected. But again, these guidelines are what we see when we want to print something out of the computer. You must use your education and your experience of the people that you work with in your community to rise above what you've printed out of your computer, and to understand the community that you are working with, and understand that they are more than the data, they are more than the guidelines. And so while we do look at the guidelines, you need to consider the importance of screening frequently, as much as possible. And I think I'm getting the wrap-up signal, but I would like to ask my fellow practitioners, nurses, to really reach out and ask what this looks like if this is a population that you have any question with. If you're questioning whether or not you should do the testing, the answer is yes. The answer is a big yes, because so much harm can come from not testing and simply following guidelines based on what the latest guidelines are, and you lose valuable time. I only have 3 minutes left, so I'm going to cut it off here in case there are any questions. I would love to be able to leave with the remaining 3 minutes that we have for any questions within the audience.
And feel free to come off of mute and ask your questions. I know there were some questions in the chat about filter first. I'm not sure who would be best to answer this. LaTricea, I know you are familiar with it from some of its work in Michigan. Is this happening anywhere else other than Michigan at this point?
So in DC, there's filtering as well. That's pretty, for the most part, robust. They also have at each site, and this is more so for the K through 12 schools. Now with childcare facilities, it's not consistent. But in DC public schools, they have barcodes, so they coordinate with the Department of General Services, where they're supposed to use that mechanism to provide oversight around the expiration of those respective filters, the date in which they were actually installed. So that's in place. And then you already mentioned Michigan. I can tell you for some other states, for example, like that's not happening in Maryland, even though they did try to mirror the DC bill. It's not happening in Tennessee. So it's very limited around that filter first aspect of the state specific. Well, DC is not a state bills.
Yeah, I'd like to add on the schools issue that and also for homes as well, that filters are really a very good idea for use at all taps anywhere that are used for drinking and cooking. However, they're not, just a magic solution and necessarily an easy solution unless they come with proper additional steps. In schools, for example, and this is a problem with DC schools, is that, first of all, once filters are installed, DC is also required to test them. So the testing happens following filter installation, not before filter installation. DC's standard for these filters is 5 parts per billion. So when the schools go back and test the filters, if the filters release levels lower than 5 parts per billion, then the school district just checks it off and says this filter is working fine. So that's a problem. It would be, that was our defeat in DC. And that was our mayor's very sudden 180 turn from promising us a 1 ppb health-based standard for filters to suddenly overnight announcing that it was going to be 5 parts per billion. That's a problem. The second problem with DC, and we might see that in other schools, is that filter installation has to occur at the right and proper place. So in Washington, and the proper place is at the point of use, because you want all of the water until the very end where the faucet is to be filtered. Washington, DC has many filters that are installed underneath water fountains, and taps. And so what that means is that in many cases, the last portion of the water that flows through the plumbing remains unfiltered. So that's a problem as well. And additionally, there are problems, including in DC, and I think for sure in other school districts, around transparency. So the school district with us is not happy, and at times has not been willing to allow parents to go in and watch the testing that gets done of filters. So all of these issues need to be straightened out. And same with homes. Filters need to be the proper filters. They need to be installed properly, maintained properly, replaced properly. And we all need training to do that.
Thank you, Yanna. And with that, we are at the top of the hour. I know there were some questions we didn't get to. I'm putting my email in the chat. We will go through the chat and we will send out all the resources tomorrow. A number of our speakers have given their emails, so you can also reach out to them as well. But I want to thank you all for joining, and you will hear from me tomorrow with the resources. So thank you all so much, and thank you to our speakers. Such a wealth of information and expertise. So thank you so much.